Hello and welcome to your Introduction to Simulation module. I'm Chesky, I'm part of the Sim faculty here at the hospital, and this module has been designed for you to watch prior to your simulation session with us to give you the confidence to start your simulation day feeling prepared and ready to go. So the aim of this session is to show you the capabilities of our SimMan 3G Plus mannequin, as well as showing you around our sim lab, and then we're going to do a quick recap of your A to E assessment, as that will form the crux of your simulation session with us. So first of all, we'd just like you to watch the video on the next slide, which just gives you an introduction to our sim suite as well as our SimMan 3G mannequin. I'm going to talk you through now the kind of features of our SimMan 3G mannequin, just so you know what to expect during your simulation, show you a little bit of what he can and can't do, and where to find pulses and look for things like that. So if we start kind of going from a top to tail approach, so starting at the head, he's a pretty good mannequin, he's fairly intuitive. So things that he can do, he can sweat, and he can cry, and he can also have CSF kind of coming out of his ears. That may or may not happen during your simulation today, but just so you're aware, that's something he can do. His eyes, as you see, can blink, and they will react, his pupils will react to light, so they should shine, they can be pinpoint, they can be dilated, and they will respond accordingly as to how the simulation is meant to be run. From a mouth perspective, if the patient is cyanotic or have low SATs, then you'll see a little blue light, which we'll show you in a minute, in the mouth that glows blue to represent that cyanosis. He can also have tongue swelling, so if there's an obstruction, that tongue can swell. If you hear in your simulation some kind of snoring sounds, or you think that you're worried that the airway isn't patent, he is able to have a jaw thrust and a head tilt chin lift performed on him to try and help open that airway. He can also take airway adjuncts, so he can take an MP airway and an oropharyngeal airway. He can also take an LMA, and he can be intubated. If you are going to use any of those adjuncts, so you need to just use a little bit of lubricant as shown to try and make sure that they slip nice and easily into him. So that's probably everything on his face and on his head. Then moving down to his neck, so he has got carotid pulses on either side. The best way to feel all of his pulses as we go down is to press kind of hard inwards and then gently release, and you'll start to feel that pulse. So he's got one on both sides of his carotid. He can also have front of neck access if needed. Then moving down onto his chest, I'm just going to expose him now. So when you have your stethoscope, you can have a listen. He's got breath sounds on both sides. He can also be lifted up, and he's got posterior breath sounds as well. And that can be set to crackles, to wheeze, to kind of reduced air entry on one side compared to the other, things like that. He's also got heart sounds. They're actually most loudly heard almost over the centre, but he does have them, and if you're struggling to hear them, you can always let us know. You might notice these two kind of gold pads that he's got here. This is for in a cardiac arrest situation. These are where the defib pads need to be attached to. They're the normal defib pads that we use on real patients, so they should be easy to use, should know how to use them. Stick them on over these pads, and then the defib can be used as normal. He has also got four ECG electrodes, which can be attached as well if needs be. Then otherwise, from a chest perspective, that's probably about it. His abdomen can distend, and there should be bowel sounds heard over that area as well. They can also be changed, so have a good listen. Then on his arms, he can have IM injections done on either side up here if needs be. And then he's also got two areas that can be cannulated, one on either side. You can use a normal cannula for that. In terms of pulses on his arms, he's got brachial and radial pulses. Again, feel for them in the same way that we talked about with the carotids, by pressing down, then releasing. And they are in both areas on both sides of his hands. He can have a SATS probe attached to his finger as well, and I'll talk through the monitoring in a minute, but that will all come up on a screen for you when it's attached by the nurse. His arms do articulate in ways that they should in a normal person as well. Then just moving down, so if I just expose up here, the final pulse kind of in the top half of his body is his femorals. So again, got one on either side that you can have a feel. He can be catheterised, only using a 14 French catheter, but the simulation tech will let you know if that's going to be something that's going to be part of your simulation today. His legs, unfortunately, can't recreate swelling or anything like that, but he does have pedal pulses, both dorsalis pedis and
posterior tibial. So you can have a little feel, again, as we said before, press and let go. And they're on both sides as well. In terms of SimMan, I think that's everything to tell you about. So the only other things to mention, we have a monitor which will show you the observations on. We also have a phone which is live, and you can phone for help and advice on that. We can talk you through that in a minute. We also have oxygen stores at the back with lots of different oxygen supplies available, so the nurse who's in here helping you with the simulation will be able to help you access those different ones. And that's probably everything. Enjoy your sim.
Hopefully that video was informative and has allowed you to familiarise yourself with our equipment. We're now going to run through a quick recap of the A to E assessment. So the reason that we approach our assessment in the A to E order is to address the most life-threatening issues first and then deal with the less life-threatening issues as we go down. The easiest way to think about this section, in my mind, is in 3 stages. So for each section of our A to E, we need to think about examination, so what are we actually assessing on the patient? The observations and tests, so what are we looking at on our OB screen that's relevant to that part of our assessment, and what tests might we want to request? And then intervention, what interventions might we need to do in that part of our assessment? So firstly, if we look at our airway, on our examination, we're listening for airway noises, so any added sounds, any stridors, any obvious foreign bodies, secretions or edema that might be blocking our airway. If the patient is talking to you, then that's great, the airway is patent. In terms of the observations, we might want to have a look at our end tidal CO2 if we have one available, as that will give us a good indication as to whether the patient is maintaining their own airway. You could also have a quick look at the O2 sats as well. Then on intervention, once we're happy that the C-spine is cleared, we can then think about some simple airway adjuncts, but firstly think about the manoeuvres like the head tilt chin lift or the jaw thrust. If these aren't sufficient, we may need to use our adjuncts, as we mentioned. So firstly, we might try a nasopharyngeal airway. This, remember, is contraindicated in patients with suspicious of a basal skull fracture. So we may need to use an oropharyngeal or Guedel airway. If this also isn't sufficient, we can then think about an LMA or I-gel airway, which can have a bag valve mask attached. And ultimately, our only definitive airway is an endotracheal tube, which would be put in by anaesthetics. And that concludes our airway assessment. So moving on to breathing, we're going to have a look, listen and feel approach for this. So have a good look and listen to the chest, checking that there's equal air entry, no crackles, no wheeze, and also feeling if our trachea is central. Then on our observations, we're going to have a look at our rest rate as well as our oxygen levels or SATs. We might think about ordering a chest x-ray if it feels indicated, and possibly an ABG if it's indicated in the situation. In our intervention in B, we might need to give the patient oxygen, whether that's via nasal cannulae or a non-rebreathe mask as shown here. We might need to give them nebulizers if indicated, and possibly might need to do a needle decompression if we're suspicious of a tension pneumothorax. We also can give ventilation support by giving breaths through a bag valve mask if the respirator is low. And that concludes our breathing assessment. Then for circulation, again, have a look, listen and feel. So listen to the heart sounds, have a good feel of the pulse, and check there's no obvious signs of bleeding on the patient. On our observations, we want to have a look at our heart rate and our blood pressure. We also need to consider whether we need to do an ECG or not. And then for intervention, this is our point where we need to get IV access, considering how many IV access points we might need and what size, and at the same time taking our blood test that we want to get. We may need to give our patient fluid or possibly blood if they're bleeding. And that completes our circulation assessment. Then in disability, if we have time and are able to do a formal GCS, then that's great, but if not, an AVPU scale is sufficient enough. We then also need to check that the pupils are equal and reactive to light and do a basic neuro examination if possible. Then in our observations, D for don't ever forget the glucose, so make sure we've checked our patient's glucose level. We may need to give them a different form of glucose depending on their level of consciousness and the level of their glucose. And that completes our disability assessment. And then finally, exposure or everything else, so making sure that our patient has been fully exposed, checking for any signs of rashes or track marks, have a good look at their feet and then do an abdominal examination, as well as for checking any other injuries we may have missed. Then on observations, we need to check their temperature. We also might want to consider requesting any other imaging that we haven't yet done. And for interventions, we might need to consider a bear hugger if they're cold, or ways of cooling the patient if they're hot. and think about any other medications they might need for symptomatic relief, but also to treat anything you found. And that completes our exposure. So this is our full A to E assessment. Remember to go back and reassess after each intervention has been made. This can be used for your recap of your learning if you need it, this table. And that concludes your module. I hope it was useful and enjoy your simulation day. We look forward to seeing you soon.